Good afternoon and welcome. My name is Tom Moore. I'm Media Relations Director with University of Iowa Healthcare. We're glad you have tuned in this afternoon to learn about the newest surgical options available to achieve safe, effective weight loss. Before we begin, I have a few housekeeping items. We invite you to use the Submit a Question box to ask our presenters a question during their webinar. Questions will be answered at the conclusion of the program as time allows. Please check our website, the link appears on your screen, for upcoming educational programs across the state of Iowa for children and adults. And now, let's introduce our presenters. Isaac Samuel, MD, is a professor of surgery. Peter Now, MD, MS, is a clinical assistant professor of surgery. Dana Jones, DNP, ARNP, is a doctor of nursing practice and an advanced registered nurse practitioner in the Bariatric Surgery Clinic. Now, let's begin our presentation.
Good afternoon, everyone, and welcome to the Bariatric Surgery second webinar series. And we are from the University of Iowa Bariatric Surgery Program in Iowa City, University of Iowa Hospitals and Clinics. Welcome to you all. In today's talk, I would like to emphasize some of the important things that have changed the field of bariatric surgery over the past couple of decades. Number one, the minimally invasive approach. And number two, the metabolic aspect of bariatric surgery, or the metabolic impact of bariatric surgery. And third, the centers of excellence nationally that have improved outcomes and safety and the culture of the specialty. This is our surgical team. Jessica Smith did her initial training in New Mexico, Albuquerque, and then did her bariatric surgery training at the University of California in San Francisco. And then Dr. Peter Now was a medical student at our institution here before he did his surgical training in Ohio, and then did his bariatric training at Mass Gen Hospital affiliated to Harvard University. And I did my medical school in Bangalore City in India, Bangalore Medical College, and then did further training in England for a few years, and then worked and trained at Northwestern University and Rush University at Chicago before joining the faculty here. Many of you might not know, but our Department of Surgery here at the University of Iowa has a significant place in the history of bariatric surgery. In 1966, Dr. Edward E. Mason conceived and performed the first gastric bypass for severe obesity. And therefore, our department is considered the birthplace of obesity surgery, and Dr. Mason is widely regarded as the father of bariatric surgery. He dedicated his entire life to helping the severely obese patient, and he's also the founding president of the American Society for Bariatric Surgery, which in fact changed its name more recently to the American Society of Metabolic and Bariatric Surgery to emphasize the metabolic impact of surgical weight reduction. Additionally, in the year 2000, our department performed the first laparoscopic gastric bypass in the state of Iowa. Dr. James Maher, who was the director for several years, and Dr. Cornelius Doherty, who was a past president of the society, and I, the three of us performed the first gastric bypasses in the month of May 2000 here in Iowa. In this picture here, you see Dr. Cornelius Doherty in 1981, along with Dr. Edward Mason at a meeting, at a bariatric surgery meeting here. In 1991, the National Institutes of Health, also called the NIH, had a consensus development conference where they announced that obesity is a disease. Prior to that, it was a widespread belief that it was not a disease but just a behavioral problem. However, the NIH not only confirmed that it was a disease, but also went on to say that gastric restrictive or bypass procedures could be considered for well-informed and motivated patients with acceptable risks. And they also stated that there is a low probability of success with non-surgical means. The NIH criteria of bariatric surgery include a body mass index above 40, normal is between 19 and 25, or a body mass index equal to or above 35 with associated complications such as diabetes, high blood pressure, etc., or 100 pounds above ideal body weight or twice ideal body weight. In our program, we currently offer mainly two procedures: the laparoscopic gastric bypass, the Roux-en-Y gastric bypass, and also the laparoscopic sleeve gastrectomy. This is the surgical anatomy of the Roux-en-Y gastric bypass. First, we use a stapler to divide the stomach at this point to create a small pouch, and this is the restrictive component. And then the small bowel is divided, and the distal small bowel is taken up and hooked up to the pouch, and the proximal small bowel is hooked up to the jejunum with an anastomosis to re-establish continuity of the bowel lumen. This pouch is the restrictive component of the procedure, while the bowel bypassed here, where the food goes down without mixing with digestive juices, and this bowel here, where the digestive juices reach this point without mixing with food, that is the malabsorptive component. Therefore, the gastric bypass is a combined restrictive and malabsorptive operation. And there is also a third aspect, which is over recent years a new dimension in its impact on obesity or weight reduction, and that is the endocrine and neurophysiological effect of these changes. Changing the anatomy like this also makes certain changes in the hormones in the body and the neurological pathways that also impact not only diabetes but also several metabolic aspects such as diabetes, etc. And this is the sleeve gastrectomy, where we use a stapler to divide the stomach from this point all the way up to create a narrow tube, which is called a sleeve, and this is approximately 20% of the volume of the stomach, and the remaining 80% of the stomach is resected and removed. Therefore, in the sleeve you only have a restrictive component but no malabsorptive component. On the other hand, you do have an endocrine aspect where the resective component, that is resecting this part of the stomach, also has certain endocrine and neurological impact on the metabolism of the body and impacting the complications of severe obesity. This is a diagram showing the open operation. In the open surgery, a large incision was made on the front of the stomach, and the entire operation was done through this open technique. However, the open technique caused numerous complications. First of all, the wound-related complications such as fluid collections and horrendous wound infections where the entire wound had to be laid open, and it took several weeks to heal, and that was quite difficult both for the patient and for the surgeon. And then in the long term, you had incisional hernias appear in these open wounds, and at least 1/3 of the patients needed a second operation, most often with insertion of a mesh to repair that hernia. Hospital stay was 4 to 5 nights, and recovery was several weeks. Nowadays, it's occasionally used for patients with previous open surgeries where, because of the scar tissue from the previous open surgery, it is difficult to do the laparoscopic approach. But in our program, we perform many of our laparoscopic revisions where previous open surgery, where bariatric surgery was performed. For example, the commonest example is a previous operation called a vertical banded gastroplasty, which was done open in the 80s and 90s. And many of those patients have now to be converted either to a bypass or to a sleeve. And even though they were open surgery in their first operation, in our program, we approach them laparoscopically. And we spend a lot of time, very often more than 2 hours, taking down the scar tissue laparoscopically before we start our operation. And to the best of my knowledge, we are the only program doing laparoscopic revisions of VBGs and other revisions in the state of Iowa. On the other hand, the laparoscopic approach is a minimally invasive approach. Here, we use several ports after insufflating the abdomen like a tent by using carbon dioxide gas. Through this port, we insert a video camera and watch the interior of the abdomen on a video screen and perform the surgery. And these two ports are for the surgeon's right hand and left hand, and that port is to retract the liver. And here we have a surgeon's assistant port. So through these keyhole incisions, approximately 5 to 6 in number, we perform the entire operation. The gastric bypass done laparoscopically is one of the most complex, minimally invasive operations done today, and it needs a lot of training to be done safely. The incisional hernia rate is extremely low. We've had zero for several years because of the technique that we use now. But the holes are so small and they close so completely that it is not possible to have a hernia through this for the rest of your life. The infection rate is extremely low, much less pain, recovery is quick, and there are much less adhesions or scar tissue in the body. So the gastric bypass has the restrictive component and the malabsorptive component, while the sleeve has the restrictive component and also a resective component. On the other hand, it is too early to tell whether the bypass or the sleeve is the best operation, whether one is superior to the other, or whether in the long run both will be options and there will be specific indications for one or the other. And the reason for this, the reason for it being too early to tell, is because we have more than 50 years of history with the gastric bypass, while with the sleeve, with the laparoscopic approach in large numbers and with long follow-up duration, we have very few patients because the sleeve really became popular over the past few years. On the other hand, the complication rates from the more complex operation, which is the bypass, are coming down. One argument or debate against the bypass is that it is a complex operation. But then if the complication rates of the bypass are coming down substantially, then it is still an option to be used. So at this point, I would say that the choice of surgery should be individually tailored for each patient based on the patient's individual circumstances and the surgeon's experience and outcomes. The lap band, on the other hand, is kind of going out of fashion. It was mainly pushed by the private industry and with a lot of advertising, but really, if we look back, too many patients who've had the band inserted have had to have it removed or converted to a bypass or a sleeve. And the complications are many. So I call it the band on the run. The possible complications are band erosion into the stomach, slippage, leaks, tube-related complications, port site infections, flipped port, esophageal spasm and dilatation, reflux. Repeated adjustments of band is necessary, and there's a high removal rate and conversion to gastric bypass or sleeve. One of the main metabolic impacts of gastric bypass is seen in the treatment for diabetes mellitus type 2. It made headline news in February 2007 when the NIH issued an official statement that gastric bypass surgery is better than insulin in the treatment of diabetes mellitus type 2 in the morbidly obese. Also, the gastric bypass is the international gold standard for several years. The benefits of surgical weight reduction are many, and it reduces the related problems of severe obesity, such as sleep apnea, high blood pressure, diabetes, asthma, joint pains, stress incontinence of urine, hyperlipidemia, which is high cholesterol or triglycerides, heartburn, which is GERD or gastroesophageal reflux disease, and even migraine, infertility, and hyperlipidemia can be improved significantly, as shown by papers published from our program. Many of these problems resolve 80%. Now, this slide shows a summary of the outcomes of the American College of Surgeons, who collect national data. And here we have the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, which is run jointly by the American College of Surgeons and the American Society for Metabolic and Bariatric Surgery. And this data is data from our program collected by the college and compared to the rest of the centers of excellence in the country. And here we see numbers from January 2013 until December 2013. Incidentally, the 2014 numbers have not yet come out. So during this period, our program performed 95 laparoscopic gastric bypasses. And here you will see that the gastric bypass related readmission rate was 0. The bypass related intervention was 0. Bypass related reoperation was 0. All cause reoperation was 0. Bleeding and leak was 0. Therefore, with 95 gastric bypasses in 1 year, with 0 leaks and 0 bleeds, 0 interventions, 0 reoperations, and 0 readmissions, our program has established itself amongst the cream of the best programs in the country. And this data is collected nationally and audited and comparing each program to the other programs in the country. So the recommended plan for obesity surgery: you see a dietitian, start an exercise program, and then stop bad habits like drinking too much of pop and snacking and smoking. And if you come to the University of Iowa Hospital, you will experience excellent patient education, very low complication rates, being one of the safest programs in the country, and long-term or even lifelong follow-up. Here is a success story. This patient started off at 250 pounds with a body mass index of 43, and she worked full-time as an accounts manager. She had borderline hypertension, heartburn, stress incontinence, and other problems. And 1 year after a gastric bypass, she came down to 131 pounds. She lost 120 pounds and gained a husband. And she follows a diet and exercise regularly. All her comorbidities resolved. And even with the infertility that was present before the operation, she had a 3-year-old a few years later. Now, bariatric surgery will only work if you work with it. It is not a cure, only a tool to help you reach your goals. Therefore, you need to be educated well, you need to be compliant, go to a program where there are safe outcomes, and then in the long term, you need to continue the education and follow-up, where you go back to your program and keep an eye on things. There are several centers of excellence designations in the country, and the Center of Excellence is the third factor that has impacted the popularity of bariatric surgery over the past several years. Number 1 was the minimally invasive approach. Number 2 was the metabolic approach. And finally, the centers of excellence that started in the country also impacted everything because of the improved outcomes and the criteria for becoming a center of excellence. And this is our program team here, where we have 3 surgeons and coordinators and nurses and physician extenders. And we also have Chris Melichar, who works on the insurance pre-approval, and Amy is our dietitian. And today, Dana will address you, and Dr. Peter Now will also talk to you. Thank you very much. And now, I would like to request Dr. Peter Now to address the audience. Thank you.
Well, thank you for the opportunity to talk with you guys today. This is a topic that we're really passionate about, and we appreciate you giving the chance to talk a little bit about something that we think is a big issue in society today. So I have 3 objectives for my talk today. I'd like to first define the obesity epidemic that we have in the United States. I'd then like to discuss the complications associated with obesity, and then spend a little bit of time at the end outlining the successes of weight loss surgery and why we really think that it's the one real answer for the obesity epidemic that we have. So I think one of the first things you have to do before you talk about why obesity is important and what we do to fix it is to talk about what it isn't. So obesity isn't just a cosmetic issue. It's not something that happens just because people eat too much, and it's not caused by a lack of self-control. Well, what is obesity? According to the World Health Organization, obesity is a chronic and progressive disease. It's a combination of both genetic and environmental factors, and it's an important public health issue, not just for adults, but also for kids. And like I said, it's a progressive disease. When someone becomes obese, it makes changes within their body that puts them at risk for gaining more weight. And it's a disease that we have to treat individually according to each patient. This isn't a one-size-fits-all the way that we treat this. This is something where you sit down with a patient, you develop a plan of attack, and you go at it that way. So like I said, obesity is something that we need to treat as a disease. So broken down very simply, obesity and overweight are defined as an abnormal or excessive accumulation of fat that can impair a patient's health. Well, how do we measure that today? Currently, we use the body mass index. So we take the body mass index, which is an adult's weight in kilograms divided by their height in meters squared. And we break that down and we use that to tell when we would expect people to have the complications related to being overweight or obese. Now, this isn't a perfect tool, but it is the tool that we have today. It doesn't accurately measure fat content when you're talking about the proportion of fat versus lean tissue mass. So if someone's very strong or has a very big frame, they may have a higher BMI despite not being classically obese in appearance. It also doesn't measure where people keep their weight. We know from research what we've seen over time is that when people have more of an apple sort of shape to their body, that they have the complications of obesity at a much lower weight than someone that has more of a pear shape to their abdomen, and the BMI may not accurately reflect those differences. It also doesn't reflect the differences that you can see in race and even sex. We know that Asian populations and some Native American populations are going to experience the complications of obesity at a much lower BMI than you may see in a Caucasian individual. And then lastly, it doesn't address the fact that as many as 25% of Americans are going to have unhealthy metabolic profiles despite having a normal BMI. So when we break down the BMIs, we see that if your BMI is less than 18.5, you'd be considered underweight. A normal weight is going to be anywhere from 18.5 to 25. You start talking about a person being overweight when they're 25 to 30, and then once you get above a BMI of 30, you start talking about obesity, with class 1 being 30 to 35, class 2 being 35 to 40, and class 3 or severe obesity being a BMI of greater than 40. Now, one of the things that I think that it's important for us to acknowledge that this is something that's been coming on relatively recently, which I think is encouraging because it shows us that we have the ability to make a big dent in it as a public health problem. The BRFSS, which is the Behavioral Risk Factor Surveillance Survey, is the longest running telephone survey in the United States. In 1985, they started collecting obesity data or weight data on the population. And you can see early on with the white data that there wasn't a great deal of information from a lot of the states. When you move up to 1990, though, you can see that the obesity rate wasn't that high, with no state having an obesity prevalence greater than 15%. As we move forward, though, you can see that the map becomes darker and the prevalence of obesity increases. Moving up to 2000, there was no state with an obesity prevalence greater than 20%, but there is a significant increase of obesity. Moving up another decade, you can see we're adding new categories. And by 2010, there were 36 states with obesity prevalence greater than 25%, and 12 states with an obesity prevalence greater than 30%. And with the most recent data, you can see that now there are 2 states in the United States with an obesity prevalence greater than 35%. This really is an epidemic that we need to start addressing in our adult population. Now, with that said, this isn't just an adult problem. The obesity rates for children have doubled in the past 30 years. And over that same period, the rates for adolescents have tripled. And this isn't just an epidemic in the United States, it's really an epidemic across the world. Worldwide, there are at least 500 million adults that are obese and another 1.4 billion that are overweight. 42 million children under the age of 5 were obese or overweight in the world in 2013. This is a graph, and what this represents are some of the countries that record their obesity, with the worldwide average of obesity somewhere around 18%, the United States coming down in here around 35%. So this is something that we need to address both on a national and international level. So why do we care about obesity? Why is it something that we as physicians and clinicians worry about so much? Well, number one, there's diabetes. So there's two types of diabetes. There's type 1, or what we used to call juvenile diabetes, where the people lack the ability to make insulin, which is the molecule that helps us control our blood sugars. Type 2, which is 90 to 95% of the cases, happens when your body becomes resistant to that insulin that your body makes. What we know now is that with a BMI greater than 35, the person's risk for developing diabetes is 50 times higher, and obesity is the single best predictor for the development of diabetes type 2. Well, why does that matter? Almost everybody knows someone with diabetes today. Well, diabetes is a significant predictor for bad health complications. It's the number one cause of kidney failure. It's the number one cause of blindness. It's the number one cause of lower extremity amputation outside of a traumatic setting. The risk of stroke or complications from cardiovascular disease is 2 to 4 times higher in people that have diabetes. And when you talk about someone that's diabetic, their life expectancy can go down between 12 and 14 years. Diabetes was the 6th leading cause of death in the United States in 2002 and accounts for over 200,000 deaths each year. Well, what about cardiovascular disease? Heart disease is the leading cause of death for both men and women in the United States. Approximately 700,000 people die from heart disease each year, and obesity is an important risk factor for this. People that are obese are more likely to have high blood pressure and high cholesterol. They're more likely to have congestive heart failure, and they're more likely to have coronary artery disease. And as the obesity increases, the level of someone's obesity, so too does the risk for heart disease. I think this is best illustrated by these two maps. On the right, again, you see this is the 2013 data for the obesity prevalence in the United States. And this is the prevalence of heart disease death rates from 2008 to 2010. And you can see that where it's the darkest red is where we see the most obesity in the United States. This is a significant problem. What about the lungs? Does obesity affect the lungs? The answer is yes. Approximately 25% of obese people have asthma. Another 50 to 60% are going to have sleep apnea. Now, sleep apnea just doesn't make you tired. It just doesn't make you have daytime drowsiness. It also increases your risk of dying from heart disease and developing heart failure. It increases your blood pressure and it increases your cholesterol. It's a significant health problem. And I think something we're seeing more that's been under-recognized is that obesity does increase the risk of you developing cancer. As early as 2007, there were approximately 34,000 new cases of cancer in men and over 50,000 cases of cancer in women that were attributed to obesity. In 2030, that number is expected to balloon to over 500,000 new cases of cancer. In the United States, as high as 20% of female cancers and 14% of male cancers were directly attributed in part to obesity. That translates to over 100,000 deaths each year. So what cancers are we talking about? Well, colon cancer has increased by 33%. Kidney cancer has increased the risk by over 84%. There's an increased risk of prostate cancer by over 12%, and endometrial cancer by over 152%, and that doesn't even count breast cancer that is obviously a very hormonally responsible cancer. So clearly this is a problem throughout the world. It also has significant health problems that are associated with it. So why are we so passionate about weight loss surgery? Well, the simple answer is because it's effective. And I think the most important thing is that it's a safe surgery. There is an 89% decrease in the risk of dying at 5 years in people who have had weight loss surgery versus a population who did not. There's a 90% decreased risk in dying from diabetes after surgery, a 60% decrease in the risk of dying from cancer after weight loss surgery, and a 50% reduction in the risk of dying from heart disease after surgery. When talking about the safety of the surgery itself, it's no more different than getting your gallbladder out as far as safety or the risk of dying, and it's safer than getting your hip replaced. Ultimately, this operation is safer than doing nothing at all. Well, what about bariatric surgery versus non-operative efforts to treat your medical problems? Well, with bariatric surgery, there's a decreased risk in both the absolute number of heart attacks or strokes, as well as the number of deaths from these events. It results in normalization of cholesterol on up to 80%. Up to 95% of people will see their sleep apnea go away. Bariatric surgery is significantly more likely to prevent the development of and improve the cure rate for type 2 diabetes. It's associated with a significant decrease in new cancers, and perhaps most importantly for a lot of our patients, it produces a significant, tangible improvement in their health-related quality of life. And really the bottom line is that weight loss surgery is going to produce a more reliable and significant impact in the patient's weight when compared to a non-operative effort. Thank you for your time. I'd like now to introduce Dana Jones, who's going to talk a little bit about the lifestyle and diet changes that we ask our patients to make as they get ready to proceed with bariatric surgery and succeed with it afterwards.
Thank you, Dr. Nell. Good afternoon. I'm Dana Jones, the nurse practitioner that's recently started on with the bariatric team, and I want to talk to you this afternoon about the lifestyle and diet changes that our patients can expect to make with their bariatric surgery. So in coordination with our patient care team of surgeons, nurse coordinators, advanced practice providers, support specialists, dietitians, fellows, nurses, and medical assistants, we really want to make sure that our patients succeed, and we want to give them those tools to help them make those changes. So changing your life means changing your lifestyle. Following our structured eating plan, learning new eating and mealtime habits, and then making those lifestyle changes to promote success and then prevent complications after surgery, as well as adding an optimal exercise routine and several other lifestyle choices are going to be essential in making sure that you're successful after bariatric surgery. So the UIHC Bariatric Eating Plan is designed to promote weight loss, and it's structured for the bariatric surgery anatomy, as after surgery you're not able to process foods in the same way. We focus on a clean, whole foods eating plan that stresses taking in nutrient-dense foods rather than focusing on supplements like shakes or protein bars. So we really want to put the knowledge in the hands of our patients. We want to give our patients the tools that they need to make those healthy choices, both before surgery to prepare and then after surgery, so that they can have lifelong success. We want to give patients the ability to determine which foods are nutrient dense, to read a food label and decipher what it says, and to wade through the misinformation that they might come across. Many products might claim to be sugar-free or fat-free, have real fruit, or have other health benefits, when in actuality it may be very misleading. Our bariatric dietitians want to work with you to make sure that this bariatric eating plan fits in with your life. So our bariatric dietitians are willing to work with local dietitians, and we also offer eHealth, which allows you to meet with the dietitian through a tablet, a smartphone, or a computer. So we really want to make sure that this plan works for you. Our dietitian is going to create a personalized eating plan for patients using this easy to use, easy to understand tool, these bubble sheets. And these really promote balanced nutrition and regular exercise so that they can have successful weight loss. So our plan is structured for success. We want our patients to have 3 healthy meals a day consisting of protein and low processed carbohydrates. We also want them to have 3 milk or yogurt snacks a day and no other snacking. We want them to sip on 6 8-ounce cups of plain water every day. When I say plain, I mean no flavoring packets or drops, as those can contain acids, which can promote ulcers, which is a major complication after surgery. When I say not sparkling water, we mean no carbonated drinks, no pop, no sparkling water, nothing with carbonation, beer. That carbonation also can contain acids, which can promote ulceration as well as stretch the pouch. We encourage our patients to keep a food diary because that accountability is really going to promote their success. In addition to the bubble sheets that our dietitians will provide to the patient, you can also use apps such as SuperTracker, MyFitnessPal, or Lose It to help keep that accountability day in and day out. So as I said, changing your life means changing your lifestyle. You need to follow the new mealtime habits, including the bariatric eating plan, but also patients need to learn to chew their food more slowly and more thoroughly, as the stomach's ability to churn and digest that food is different after surgery. We also encourage patients to avoid drinking fluid with meals or 30 minutes before and after, as that can stretch the pouch and lead to overeating. We want our patients to avoid all nicotine products, as nicotine can promote ulcers, with bleeding and scarring being the major complication with ulceration. As I said, we don't want you to drink any carbonation, as that can stretch out your pouch or sleeve and can also cause ulcers due to that acidity. We encourage our patients to exercise at least 30 minutes a day. So I've heard Dr. Samuel speaking with patients about the gas tank analogy, and I really thought this was a great way to explain to patients how diet and exercise works to help them. So food is the fuel for the body, and exercise is like stepping on the gas pedal. In order to lose weight and to maintain weight loss, we need to do both. We need to put less gas in the tank, and we need to run the car. Excess gas and minimal driving can make the gas tank and our stomachs balloon out. We want our patients to exercise as much as they can without pain. A lot of our patients can have joint pain or limited mobility. To help with that, we like to give them physical therapy consults so that they can find a way to exercise as comfortably as possible. Some other exercises that can be done for patients with joint pain would be like water aerobics or swimming. Those can be excellent options for those patients with pain. We encourage 30 minutes or more of moderate to vigorous exercise. That means, can you still sing? Can you carry on a conversation? If you can, then you're not exercising vigorously enough. Exercise, as I said, is essential for weight loss, weight maintenance, and to prevent serious complications after surgery. Some other lifestyle changes that patients can expect to make would be changes to their medication. Many of our patients have diabetes, high blood pressure, high cholesterol, and they may be on medications to treat those illnesses. After surgery, greater than 80% of those obesity-related complications are going to resolve, which means you may require reduced dosing or even eliminate some of those medications you're taking now. We also require our patients to have lifelong daily supplementation because sometimes it's hard to absorb as many nutrients as they need. We want patients to avoid all medications that can promote ulcers, namely non-steroidal anti-inflammatories such as ibuprofen or aspirin. So the role of the bariatric nurse coordinator is to work with the bariatric team, hospital personnel, referring physicians, and patients to optimize patient outcomes and improve patient quality of life. We function as the team coordinator, the clinical coordinator, the patient educator, the patient care coordinator, patient advocate, and support group facilitator. And our focus is really education. Consistency is going to be the key to your success. So surgery is only one tool that you need to succeed. Consistent compliance with the bariatric lifestyle, diet, and exercise plan is going to ensure the rest. When I talk about compliance, I mean being cooperative, eager, and ready to change. So research has shown that peer support really does improve patient outcomes. So we offer a bariatric surgery support group on the first Tuesday of each month from 6 to 7, where bariatric surgery clients can come together and speak to each other about different topics and exchange ideas and information. If you'd like to learn more about that, you can contact us at obesitysurgery@uiowa.edu. I've also included some online resources about diet, exercise, and obesity that you can access after the program. So this is a picture of success. This is our success story, Dawn Walker, and this photo is her 1 year, this photo is 1 year ago, her before photo over here. I'm pointing, but no one can see what I'm pointing at, sorry. So here's her before photo over here, and then this is her at her 1 year follow-up. And she is the picture of hard work and dedication, and I would like to introduce to you Dawn Walker. Hi. How are you doing?
Good.
So tell us when you had your surgery.
September 16th of 2014.
Okay, so you just had your 1 year follow-up.
Yes.
It was
on the 18th.
The 18th? Okay. Yeah. So what would you tell everyone about bariatric surgery, if you had one thing to say?
It was probably the best thing I've ever done in my life.
So did you have complications related to obesity prior to surgery?
I suffered from hypertension, depression. I was using a CPAP machine, and I had a lot of joint pain.
And did that resolve with your bariatric surgery?
Yes, it did.
Wonderful. In what way do you feel like this changed your life?
I'm just able to do things I've never been able to do. I can run 4 miles. I can get down on my knees. I can scrub my floor. I can play with my kids. I can run after them. I mean, my son's 15, but I am a challenge. So it's been a lot of fun just getting my weight off. And
Fabulous. So, was it easy?
no, it wasn't easy.
What do you think the hardest thing was for you?
The exercise was probably the hardest.
Exercise. What motivated you to keep going?
Well, my sons will be getting ready to be married, and soon at one time I'll be a grandmother. I want to be able to get down and play with my children.
Wonderful. If you could do it all over again, would you do it again?
Oh, yes.
Fantastic. Okay. Do you have anything else that you wanted to tell everybody?
No.
No? Well, thank you for coming.
All right,
Are we
thanks.
ready for Q&A? Sorry.
I would first like to thank everyone, the audience in particular, and I would like to thank the speakers also for coming today, and our patient also for a very positive experience she's had from the surgery. And we can open our session now to questions and answers. And we received some questions already before the meeting. And one of them inquires about insurance coverage for bariatric surgery. So it really depends on the particular insurance carrier. So if you have any question, you should really contact your own insurance carrier, because the rules and regulations can be different between each benefit program. But I would say that the majority of our patients who are having surgery on our program are being covered, and the cash pay patients are very occasional. And a second question I see is about cardiac stent. Yes, we have performed surgery on patients with complex medical problems, including cardiac stents. So we have performed the operation, so that should be no problem. Any other questions? Okay, then I don't see any other questions on the system. So once again, I would like to thank everybody and have a wonderful day. Thanks.
Please keep an eye out for an email from us within the next 2 days, which is a program survey. You will also receive a follow-up email with information and links from today's presentations. Thank you again for attending the webinar, and we look forward to seeing you at future programs.
University of Iowa Healthcare. Changing medicine, changing lives.